Okay, good morning, everyone. Welcome to How Anesthesia Clinical Outcomes Impact Patient Satisfaction and the Hospital's Bottom Line. We are pleased to have partnered with Somnia on this webinar. Today, our speaker is Hugh Morgan. He's the Vice President of Quality Assurance and Executive Director for Somnia Patient Safety Organization. And he is responsible for providing strategic vision, leadership, and oversight for Somnia's National Anesthesia Quality Assurance Program, titled Clinical Quality Excellence. Hugh works with Somnia's practice leadership and clinical staff across the country to ensure that the right systems and processes are in place to achieve high quality and compliance with regulatory, accreditation, and professional society standards. He also collaborates with hospital and ambulatory leaders to achieve the shared goal of high-quality, patient-centric anesthesia care and outcomes. Mr. Morgan joined Somnia in 2009, first managing a startup anesthesia practice in New Jersey and then transitioning into quality assurance, where he became director in 2010. He was subsequently promoted to vice president in 2012, and prior to joining Somnia, Hugh had a diverse career with more than 20 years in healthcare. After serving in the U.S. Army, he became business manager of perioperative services at Temple University Hospital in Philadelphia, followed by anesthesia practice director at AtlantiCare Regional Medical Center in southern New Jersey. Mr. Morgan earned his master's degree in healthcare administration from Grantham University and is both a certified medical practice executive and a certified professional in healthcare quality. So I'm going to turn it over to Hugh. And Hugh, if you haven't already, can you please press *7 so we can unmute your line and hear you?
Hi, Marisu, and thank you so much for that introduction. Can everyone hear me okay?
They're all on mute, but I can hear you, so you're good to go.
Okay, great. Thank you. Thanks again for that introduction, and thank you to everyone who I'm sure took time out of your busy schedules to join today's session that I certainly hope you will find to be both informative and beneficial. So before we start, here's my official disclaimer, which essentially holds everyone harmless except for me for the content of today's session. But certainly, thank you again for joining. This is actually the second time that we've done this. We did another session on more operational and financial anesthesia performance a few months back in October. So this one, of course, is going to focus on the link between outcomes and patient satisfaction. So to start, I think, just to get the context, I guess, of today's session, I think the reality is there's a lot of different perspectives out there as to what constitutes, I guess, patient satisfaction and patient experience. So really what I've arrived at is sort of what I would call the crossroads or congruence concept between what the patient expects and what actually happens to them in their care experience. So I want you to keep that in mind as we progress today. So what does, I guess, the acute care patient in today's hospital setting really expect? And I think, in my humble opinion, this is where I think things can perhaps run a little askew in healthcare, whereby I think some tend to think it's to provide sort of a Disneyland or a vacation type experience for the patient, when I think the reality is that what most people come to the hospital for these days is really quite the contrary. And I think this really starts to get to the real question of patient satisfaction versus experience, and again, especially in the acute care setting. So on one side, there's perhaps the one and only reason why people come to the hospital for that truly satisfying experience, the birth of a baby, whereas on the other side is why probably 95% or more come to the hospital, which is really for that sort of unnecessary experience. So then the question, I think, becomes satisfaction or experience, right? And you could say it's sort of semantics, but I really think there is a difference when we look at it. So when we look at the definitions of each and how I think they've helped shape ongoing health reform as we know it, I think it's clear that for the most part, the emphasis is placed on the patient's actual experience or what happened to them during their hospitalization, right? How often something occurred, et cetera. Was it the right care? Was it not the right care? Were they harmed in some way, as opposed to really whether they were sort of happy or satisfied? And certainly this became the basis of a lot of what we see today with the health reform, and certainly what has continued to shape, as we'll see, the HCAHPS discussion. So armed with that sort of knowledge, I think if we take a look back at sort of the evolution of surveying over the past really 30-plus years now, much of that evolution really developed in a 20-year span from, say, 1985 to 2005. Started with Drs. Press and Gainey. Press Gainey is sort of a known synonym with patient surveying today in healthcare. And they started this surveying instrument in the mid-'80s. And then as time progressed, I think hospitals, by and large, sort of gleamed onto that and sort of took that, with voluntary use to sort of, gauge how they were doing, right, what patients thought about their services. And then fast forward to 2005, and all of a sudden CMS started looking at patient surveying and results as a means for pay for performance. And then, of course, that then became the basis for HCAHPS and surveying. So I think if we look, it was also during that time period that the Institute of Medicine had published their second landmark study, right? The first one in 2 years prior in 1999 was the famous To Err is Human, where they really uncovered a lot of what was going on then in the health system, with errors and harm to patients. And then they followed that up in 2001 with the Crossing the Quality Chasm book, which really outlines sort of 6 dimensions for the 21st century healthcare system. And I highlight 2 of them here because I think these are the 2 that, again, speak directly to the patient's experience and again, their expectations of sort of how they were treated, is more so than certainly what they were treated or the treatment that they received. And that's do no harm and then patient-centered care. And again, a lot of that centers around communication and such. So I think 1 year later, following that 2001 Institute of Medicine book, all of a sudden, HCAHPS and AHRQ and CMS starts really looking at, okay, how are we really measuring the patient's experience? And then that sort of transcends over the next few years where, the HCAHPS surveys are developed and released. And again, like most everything else, they start voluntary in the first few years, and then all of a sudden they become mandatory. And then they really start getting included in 2008 and beyond with the Affordable Care Act and all of the patient reform that's going on. So in essence, the overview and the goals of HCAHPS is pretty standard, I think, and simple to have a standardized survey tool that can be used nationally, make comparisons amongst hospitals. Also the public reporting, right, looking at the ability to demonstrate, quality of care amongst different hospitals, and then also the transparency of the public reporting as it relates to people being able to go online to Hospital Compare and really look and see the performance of hospitals. So again, for those that may or may not be familiar with what HCAHPS does, this survey breakdown really, again, looks at 8 major areas. There's essentially 32 questions, 25 of which are what I would call sort of care or experience focus, and then the last handful of questions are really about the patient's demographics. But of those 25 care-related, 13 of them are in some way, shape, or form communication-related, which I think underlines and underscores the importance and value that CMS has placed on that caregiver-to-patient communication. And there's also a handful of questions around what I would call sort of the niceties of the food and cleanliness and bathroom facilities and such. And I highlight there on the screen in red pain management because, again, that's going to be a focus of really what we dive into as it specifically relates to anesthesia. So the content here in administration can be done by phone or by mail through an approved survey vendor, usually within a few weeks following the patient's discharge from the hospital. And again, the HCAHPS survey survey is specifically for inpatients only, not outpatients. So any ambulatory or outpatients are not included in this. The sample size tends to be relatively small. For most facilities, the number is or maybe around a couple hundred to 300 total surveys. So, if you're doing 10, 15, 20,000 admissions, it's really not an enormous sample size either that the HCAHPS survey is capturing. So here's a snapshot of the most recent publicly reported HCAHPS report from this past December based on April 2014 through March 2015 data. And this actually looks at the top box score, or the always score. So that right-hand column really represents the national mean for each of those 11 broad categories. Again, there's, the 32 questions that sort of fall into those areas. But you can see I highlighted in red, I think, the areas that certainly you could argue are the ones that are really, by and large, sort of trailing behind. And again, the others I highlighted in blue there, sort of the anesthesia one, pain management, at around 71% of the top box are always scoring. So there's definitely opportunities here for improvement. This, I think, is interesting because if you're not aware, this past year, HCAHPS actually adopted what I would call sort of a social media type scoring approach, sort of like Yelp and some other social media outlets that sort of rank consumer services and such. And I think some of this was because really the way that HCAHPS or patient satisfaction scores were being reported, it was percentage-based and normative mean, and it was really confusing to patients, again, looking at sort of like the data we just looked at, the top box percentages and such. So I think HCAHPS looked and they said, let's go to more of a star scoring system. So, 3 stars, 3.5, 4 stars and such. So this coming April, in a few months, they're actually going to be releasing publicly online the first sort of star reporting based on 2015 data. So this will be sort of interesting to see how this is received by consumers and whether it makes it more meaningful or not. Certainly, CMS has placed a high value on capturing the patient's experience. The value-based purchasing program, again, out of the Affordable Care Act, since fiscal year 2013 to fiscal year 17, you can see that pretty much patient experience of care, HCAHPS reporting has represented either a third and now down to a quarter of the value-based purchasing pie for hospital reporting to CMS. So still a fairly good weight that's placed on that for the hospital's either incentive or penalty, depending on how they score in that process. So really that's an overview, again, of HCAHPS. Again, pretty quick. We could spend a lot more time, but I wanted to just frame the context of that, which, again, is a measurement of the patient's hospital experience. So, the other side of the equation, again, as we think about anesthesia patient satisfaction or experience, is CG-CAHPS, which is the clinician and group consumer assessment of healthcare providers and systems. That's a mouthful. But essentially, I think it was really an attempt by CMS to start looking and thinking about how they could possibly capture the patient's experience with the physician provider. So essentially what happened, and this is roughly, I guess, about 10 years ago now, AHRQ, Agency for Healthcare Research and Quality within CMS, sort of developed the initial CG-CAHPS survey, which later became NQF Endorsed, and then essentially CMS started looking at this to see how they could perhaps put this into PQRS, or the Physician Quality Reporting System, for reporting, but the limiting steps here are really that this is focused on the outpatient setting or the doctor's office. The questions here really center around asking the patient about how long they had to wait for an appointment, their experience in the doctor's office. So again, this survey is really not meant for the acute care setting at all, or to apply towards that. So briefly, again, I just wanted to touch on that because I know there's oftentimes, well, can we consider using CG-CAHPS for looking at surgeon or anesthesia satisfaction, and the answer is no. So really they don't apply here, as we know. So then it becomes, well, what does apply, right? So again, in 2007, around the time that CG-CAHPS was being developed, the American College of Surgeons started thinking about this and collaborating with surgical and the American Society of Anesthesiology and different professional societies to really think about how could we capture the patient's surgical experience and anesthesia experience in surgery. So they pulled together focus groups. They looked at psychometric testing to develop a survey tool. 5 years later, in June of 2012, the National Quality Forum put their stamp of approval on S-CAHPS. But again, this is still a voluntary survey tool. So despite the ACS really petitioning CMS to allow for this S-CAHPS survey to sort of replace or augment the CG-CAHPS survey, right? Because again, it doesn't apply to the acute care setting. That's still up for debate and is being kicked around at CMS level as to whether or not that will eventually work its way into either PQRS or value-based physician modifier reporting for physicians as they report to CMS. Interestingly enough, the S-CAHPS survey, very similar size-wise to HCAHPS, around 36 questions, and it was really 3 parts. The survey is before surgery, about 13 questions about the information that patients receive prior to their surgical care, communication type stuff. The second part was sort of about their surgery, and within that grouping of 11 questions, there were 8 anesthesia questions, all referring to anesthesiologists, so none of those questions referring to either anesthesia provider or even a certified registered nurse anesthetist, which again are providing probably at least 50% or more of the care today. And you can see on the screen the 8 questions that are anesthesia related in the S-CAHPS survey. And again, I highlight sort of 3 areas I think that they comprise. One is sort of the visit type questions, the patient's visit with the anesthesiologist, pain related questions, about did they have pain, were they given something, and then what I would call communication or Q&A type questions. And then the last part of the S-CAHPS survey was after surgery, where they talk about follow-up care, instructions, discharge instructions, communication, and that sort of stuff. So that really is the S-CAHPS. So in the end, interestingly enough, even though the American Society of Anesthesiology, the ASA, was at the table for these discussions and development of the survey tool, in the end they apparently do not endorse the survey, and in fact strongly objected to the anesthesia questions. You can see the source there for this. And my sense is that, again, in the end, I think the ASA probably feared that at some point those questions would and could be used by CMS to influence reimbursement discussions, and I think that's ultimately where the fear came in. So the ultimate question, I suppose, is anesthesia satisfaction even possible? I think, certainly the inherent nature of anesthesia adds a degree of complexity, whereby trying to measure and get feedback from the patient about their experience often can be impeded by the fact that they have anesthesia on board during that. So that's really what we're going to start thinking about as we move forward. So there's a lot of literature and studies that have been done, especially in recent years, about measuring anesthesia patient satisfaction. The ASA has really sort of jumped into this, as well as other anesthesia providers. This is an extract on the screen from the Anesthesiology Journal back in 2013, where they really did a pretty exhaustive research, 32 years worth, spanning 1980 to 2012, looking at, so you can see, almost 19,000 different studies, and they really narrowed it down to only a few that they felt had psychometric testing to develop the survey tool and such. But the conclusion really was that the vast majority of the anesthesia-related studies did not use sort of the appropriate validation tools to measure satisfaction, and as such they can be, biased or misleading with the results. So this is kind of interesting in their approach. So then what the ASA did is they said, you know what, let's try to help the public as to really what they can look at and what they can be doing to look at this. So they designed sort of, you know, a roadmap of sorts, and these 6 steps as far as developing a really solid patient surveying or patient experience questionnaire that includes validity testing, reliability testing, and such, and really putting some scientific approach to the development and use of a questionnaire. And what they ultimately came up with is that the American Society of Anesthesiology said, you know what, let's develop a survey tool that can sort of serve as a standard throughout the industry that anesthesia practices and clinicians can use, and then we can eventually, you know, publish and report on this data to have some basis of comparison as folks are looking at this. So they essentially developed a pretty simplistic tool, again, a 5-point scale, but interestingly enough, they sort of developed a short survey tool and a long survey tool, of which there were different questions and 19 total different questions for both of the surveys. So here, and I apologize if the print is small, but here are the 19 different questions that the ASA recommends, you know, should be asked in a patient satisfaction or experience survey. And you can see the ones that have both the short and the long, and then the last column for both. And again, what's interesting is that there's only really a handful of questions that apply to both the short and the long. So again, that I think reduces ultimately the ability to have some effective comparison going on. But these are really the questions that the ASA felt was important. Again, a lot of which really do center around communication with the patient, willingness to listen and understanding and asking questions and that sort of thing, and then some other pain management related questions as well. So I think, like I said earlier, I think there's an inherent sort of challenge to measure anesthesia patient satisfaction because, again, of just the nature of what's happening in the delivery of care, and also because it's a team sport, right? I think it's not just the anesthesiologist, but also CRNAs, and I think for that reason it can be confusing to the patient as to who's taking care of them when and how and the different stages and processes that happen. So I think in all it can become sort of confusing. So what I often look at is really what I call the bookends of the patient's surgical experience with anesthesia. So you have the pre-op side on the left side, which is really where the anesthesia provider initially is greeting the patient, discussing the care plan, starting that Q&A communication exchange with the patient. Here's where the anesthesia provider can and should start to really have an impact on the patient and their comfort and safety as they are approaching the surgical suite. What's being done to manage all that? The intraoperative part, hopefully patients aren't remembering any of that. That really, you know, anesthesia recall is just so minimal today that that's usually taken care of. And then on the back end, right, the bookend side, on the back end is really, again, that where the anesthesia provider, again, is having that first wake-up experience with the patient, again, being able to address any of their pain or post-op nausea, vomiting, helping them with, you know, pain management, perhaps inserting blocks or epidurals to manage that, and then transferring the care. So the bookends are really what I think are most memorable for those of us I know that have had surgery. You kind of tend to remember what happens before and after, and those are critical. So now here's along those lines of the bookend concept. In the last few years, there's sort of this buzzword or concept within the anesthesia community and a model of care called the perioperative surgical home that you may have heard of. So this concept was really modeled after the patient-centered home, in which anesthesia resources in the surgical environment are sort of extended beyond their traditional role to assume more of a proactive and collaborative role with the patient's care providers both before surgery and after surgery. So there's sort of the extensions, as you can see, on the very far left-hand side and the very far right-hand side of that model. where anesthesia providers are getting more involved. And the concept is that since anesthesia is really responsible for sort of the pre, intra, and post-surgical optimization of the patient along with the surgeon, the concept is that anesthesia should really be more involved in how that patient is being prepared for a successful surgical outcome and ultimately returned back to their PCP on the back end. So this model is currently being tested around the country. The American Society of Anesthesiology actually has sort of test groups that are out there that are testing this model, and I think some of the challenge, as it does for the rest of healthcare, is sort of the resources, and it's a resource issue as to, who ultimately sort of pays for the additional resources and whether or not these resources are reimbursable and services. So basically more to follow on this sort of what I would call an emerging model in anesthesia care. So what I'd like to do now is sort of transition a little bit to kind of provide some hard facts data as to how we at Somnia have addressed this and sort of show some case study type stuff. So back around the time that CG-CAHPS and S-CAHPS was being developed within CMS, we started developing sort of an internal survey tool at that time and really kicking that around within our practices and such to see what that would look like. So we form national patient groups. We use sort of our clinicians from national practices to develop a survey tool. And our goal all along was really to have a tool that we could provide actionable feedback to our clinicians while improving definitively the quality of care and services that we were provided and how we would go about that. So we also thought it was important to develop two different surveys to get patient feedback, one from the surgical patients and two from the obstetrical patients. Because, again, we feel that those are two very different and distinct patient populations. And then we felt it was important, certainly, for us to have a third-party vendor administering the survey. So similar to a Press Ganey or the others, we contracted with a national survey vendor in order to conduct our surveys and help us develop really what amounted to again, a sort of a psychometric type of testing tool where we looked at 5 different priority areas that we felt were important to patients. They told us was important to them, and our clinicians felt that it was equally important, which is that they're treated well, they're informed, right? There's a communication process about their care options and how educated they are about their care options, how comfortable they are, both, again, prior to their surgery and following their surgery, good outcomes, were they safe, no harm, and in some instances, the timeliness and responsiveness of care, especially in obstetrics, and we'll take a look at that. So, again, we developed a very brief, understandable survey, a 5-point scale, and on the screen here is our surgical anesthesia survey, and the questions for that, 11 questions, asking about how satisfied were they with these different aspects of care. And then you can see along the right side the focus again, where, again, the focus is informing the patient and educating them, making sure that they're comfortable, and making sure that their outcomes are safe and how we go about doing that. Again, these are the same questions where you can see there's a breakdown of those bookends, the pre-op and then the post-op actually should be the bottom there. It says pre-op twice, but the last 4 questions there really are post-op questions asking them about their nausea and vomiting, their pain, any anesthesia complications, and then their overall satisfaction of care. Our survey process is fairly basic. We take files that are sent from our billing service to our survey vendor. Our survey vendor has instructions basically to reach a certain number based on our volume, to reach a 95% confidence level in order to make it a statistically valid sample size, both for the group as well as individual providers. The patients are completing phone surveys, again, within 2 to 3 weeks following discharge. The patients have the ability to leave questions or comments, which is great. They can, we certainly get those comments to the providers so that they can hear that feedback directly from the patients. We also have systems called red alerts set up where essentially any trigger of a low score will immediately alert our leadership, our chiefs and our leaders on site that the patient scored low in a certain area, and it gives them the opportunity to sort of investigate into that, which is really a great feedback tool. And then on a regular basis, we have these sort of discussions. We look at reports and data, and really going through the analytics to make sure that things are on target. This is a snapshot of our surgical survey results across all of our hospitals, and again, we break out the hospitals as well, and we risk adjust those because I think it is important, and you can see the different patient feedback about their experience based on whether it's a tertiary facility, a trauma hospital, or a community hospital, and then how that looks against the aggregated mean scores. And on the screen, I also highlighted, as you can see, number 9 and 10, where, again, these are two big indicators of patient satisfaction in anesthesia, the patient's experience with pain and post-op nausea and vomiting following their surgery. And as it turns out, those are also the two most reported sort of anesthesia events, if you will, to the National Anesthesia Quality Database that's managed by the ASA. So we certainly take a look at that. And as you can see, our numbers, these are representative of a normative mean, and we take the 5-point Likert scale and essentially convert that to a scale from 0 to 100. So certainly anything 90 and above is really excellent scoring. You can see there's some that are sub 90, but by and large, most are in the low to mid 90 percentile, which really are excellent scores based on, I think we're over 25 or 30,000 surveys now in our database over the last 5 years. So the other, as I mentioned earlier, I think the other key aspect that we measure is the OB patient's satisfaction. And here's really where I do feel that it is about satisfying the patient, and it's more than just, I guess, the experience, because, again, these, rightfully so, this is a demanding patient population, and despite that, the ASA or the AQI has not sort of endorsed a separate survey for OB, we feel at Somnia that this was important for us to develop this. And here's a snapshot of our survey questions, some of which are very similar to the surgical survey. But again, these focus on information received prior to the mother showing up in the hospital for her admission, and we talk about, did they get information about their anesthesia options in their prenatal class or their visits or other information available. And then questions 7 and 8 clearly ask the mothers that had labor epidurals about their experience with that, the response time, and were they checked on, was their pain managed appropriately, those types of very specific questions about obstetrics. And then here is a snapshot of our results. Again, these go up to 2014 because we're just now compiling our year-end 2015 data. But this data is looked at continuously throughout the year. In fact, each month, online, the online portal through our survey vendor, the practices look at the data, they share and discuss the information with their staff. And you can see the one opportunity. We also look at this, interestingly enough, by our facilities where we have dedicated OB staff, dedicated anesthesiologists and CRNAs in the hospital versus those facilities where the staff are not dedicated to the OB unit, where, there's 1 or 2 providers that are sort of floating and addressing, OB services as needed. And you can see sort of the difference there in scoring between the hospitals that have the dedicated staff and those that don't. So this is also an area that also impacts the HCAHPS scores, because by the inherent nature of OB, these are all inpatients. So all of these clearly are impacted on HCAHPS. So what really matters ultimately in the anesthesia patient experience, another interesting tool that we use is the Pearson's correlation, where it essentially looks at all of the data. And if you run it through the Pearson model, it essentially will tell you, based on the patient's feedback, which questions most ultimately determine the patient's overall satisfaction. So the top line you see is the overall satisfaction, which has always the highest correlation. That's a 0.85. A 1 would be a perfect 1-to-1 correlation. Certainly anything above a 0.6 is really determined to be a strong correlation, but I highlighted those 0.8 and above because those tend to be, when we look at, again, over 20,000 surveys, what the patients are telling us really is important to them. One is, questions, communication with the care provider. Was their pain well controlled? Were they comfortable and safe? And the response time for epidurals. So all of these are direct correlations. It doesn't necessarily mean that those are the lowest responding. What it means is that patients say that if they answered in a certain way for those questions, then that essentially dictated how they would answer for overall satisfaction. So interestingly enough, there's studies out there as well that talk about, well, we do a lot of measuring and data collection, but are we really using that data to do any sort of improvement? And here's a study that basically says from a few years ago that hospitals certainly place an emphasis on measuring patient satisfaction, but rather than improving the patient's ultimate experience and what's really being done to them. And I think this also sort of follows along the recent NSQIP study that came out last year, where it sort of looked at the NSQIP hospitals in the same light, and they said, boy, there's a lot of data collection going on and studying and analyzing, but there's really no action with that data on the back end. So I think that's always been a goal of ours, is really to have some action that can accompany the data that we're looking at. So what to do with the survey results? Again, I think our approach is always to give feedback to our clinical staff so that they know how they're doing, educate them about sort of the value and impact of these measurements. I think real time is important as well. That real time feedback that we can provide to the clinicians, as opposed to talking about data that's 1 quarter old or so. Like HCAHPS comes out, and when you look at the HCAHPS report, typically by then you're looking at data that's already a quarter or more in the past. So I think we look at sort of real time. We look for trends both with the practice and individuals. Certainly want to have statistically significant and meaningful results, which means greater sample sizes than, again, sort of the national surveys and what's done there. And we continue to educate. We do a lot of peer mentoring and coaching, which works well. It's non-threatening, but, it's sort of train the trainer. There's some that are really great at sort of satisfying the patient or that patient experience, again, with the bookends of care, and others that really are not as personable. So we help those folks, and we have them align up with people who are doing a great job. And I think ultimately it's connecting the dots between the feedback that we get from patients and then our care processes and outcomes, and how we ultimately use those to improve care. So the reality is that outcomes can and do impact the patient's anesthesia experience, and especially if you kind of think of it in terms of what I would call the building blocks of anesthesia quality, and how those building blocks are so key and important to ultimately lead to the top, which is the patient's experience, and also surgeon satisfaction is there as well. But I think ultimately the focus there in validation is experience of care. So how do we do that? Well, we link basically their experience to outcomes, and we do this through our outcomes tool that we use to capture data on every single anesthetic that we deliver. So that's the form on the right-hand side of the screen. There's many practices that are using this, and what we looked at is, okay, how can we take this and essentially use it as checks and balances with what the patients are telling us. So we asked the patients again about did they experience any nausea and vomiting or pain or any complications, and those all are direct links to what we're asking our clinicians. So in other words, if our clinicians are not sort of reporting and telling us that things are happening and patients are, well, then we know there's a disconnect there. So it's a good checks and balance for us. And I would say it's sort of like a flywheel from our perspective, that the patient's anesthetic experience is sort of active and ongoing, in which our processes sort of determine our outcomes, and that, of course, determines the patient's experience, which again influences our care processes and outcomes and delivery models, and it's just sort of a continual flywheel for us. And certainly, even if you think again about process, outcome, patient satisfaction, and the link there, preoperatively, postoperatively, and how the impact of our care, our actual protocols, and our care delivery is really influencing the patient's experience and their feedback. So With OB satisfaction or experience, we link that again to service delivery. We have the questions there on the left-hand side that we ask the mother about with their labor epidural. Did the care team respond to them in an appropriate time with the epidural? And then what do we do on the right side? Well, we track that response time. We track the arrival time of our anesthesia provider to the time of epidural insertion. We have goals that people are aware of. These are real, tangible targets that we go after. We also ask them, did the care provider check on them to make sure that they are receiving pain relief? Post-operatively, even though epidural follow-up is not a requirement because it's not anesthesia, it is a standard with insomnia that our care providers are following up on the patients and making sure that they're comfortable. So along those lines, I always get the question, well, what do we do to incentivize, our clinicians, and should they be incentivized to achieve certain levels of patient satisfaction or experience? And I think there's two sides of this, and I really don't subscribe, to be honest, to one side or the other, but here's some studies on the screen here where essentially physicians have said, to be incentivized for patient satisfaction or experience really sort of undermines them in their medical judgment and sort of this dilemma between providing what they view to be the right treatment versus what the patient expects, and ultimately will that impact the patient's feedback and impact HCAHPS results and so on and so forth. So there's also those, again, that, here's the former director of Press Ganey noting that, just the response rates and the sample sizes are often too low to produce any sort of reliable results, which, again, is why we always strive and hit statistically significant sample sizes with our surveying to ensure that we don't fall short. So what's worked for us, I think, it's really been a core strategic focus of ours and dedicated resources and to make sure that the culture exists within our organization and our practices that really buy into the importance of this. Innovative development, we continue to innovate. We're now testing a real-time tablet survey that patients can use, real-time to tell us their feedback. All of this comports with CMS. I've checked directly with CMS to see if there's any conflict with the HCAHPS survey, and I've received guidance and approval on that from CMS, so we always make sure that we're not sort of impeding on what the hospital is doing for their surveying. I think certainly partnering with a credible, flexible survey vendor that's a third party to help develop and go down this path. Leadership expectations and accountability, certainly collaborating with the hospital, making them aware of what we're looking at and how this impacts what they're trying to do and their goals, educating the patients and really doing something with the results. I think ultimately that's what we're all about. But again, what I would say is having the recipe doesn't always equal consistent results. You can have the cookbook and you can know sort of exactly what to do and here's the survey and how to administer it, but ultimately it boils down to, I think, having the right leadership and management accountability to ensure that these results are being consistently met. So it's not easy, but there, I think, are some keys to a positive patient experience. Again, I think it begins, as it does with anything, with leadership and management that's effective. The collaboration with the hospital. Oftentimes I will hear that, again, the anesthesia group is sort of distant and they're not really engaged with what's going on with sort of the hospital folks that are doing patient surveying. So I think that's key to make sure that there's an alignment there and integration. I think the results and the feedback to the clinicians is super important. Again, we have all these expectations of our anesthesia clinicians, but how much really information are we providing them and letting them know how they're doing on a regular basis? And this, again, is just one element, a key one, of so many sort of what I would call key indicators that should be used to measure anesthesia performance. There's outcomes, there's productivity, there's satisfaction, there's so many. And again, I think it requires effective management and leadership to ensure that those are being hit. Some take-home messages, again, I think the key here is linking the process, the care delivery processes with the anesthetic outcomes and then ultimately how that's impacting satisfaction or experience in a real-time, actionable sort of way, so that, again, the results are tangible and something can be done with it, because ultimately satisfied patients equals loyalty to the hospital or the organization, which is growth and certainly bottom line revenue. So, that concludes today's session. Certainly, we could have gone on a lot longer, but again, I hope that it painted a picture of the importance and value of anesthesia, patient satisfaction, or the patient's experience with anesthesia, and some key things I think that you can and should be looking at as it relates to your anesthesia service. So at this time, I'd like to stop and see if there's any questions that I can take.
Okay, so thank you for that. If anybody does have a question you would like to ask, you can go ahead and press *7 to unmute your phone line to be able to ask your question. We'll give it a second here. If you do have a question, once you get on the line, just be sure to state your name and your facility for the presenter.
No questions, huh? Hopefully that means that folks felt it was effective and you got a lot of information. Certainly, I'd be happy. Again, my contact information is on the screen. Another thing to put out there is that I will be speaking at the OR Manager Conference that's coming up in Glendale next month. I'll be there on February 23rd, speaking at that conference about basically anesthesia's important role in managing the operating room and the impact on the bottom line. So if you're in the area and you happen to be attending that conference, the OR Manager Conference, I look forward to maybe meeting you in person and chatting with you then. But otherwise, my contact information is there, so please feel free to reach out at any point.
So again, I wanted to just say thank you very much to Hugh for the wonderful presentation. As he said, the contact information is on the screen. It's also in the copy of the presentation you received via email. So please feel free to reach out to him if you do have any questions that you would like to follow up with. He's more than happy to respond. This concludes today's webinar. If you have any questions for the Arizona Hospital Association, you can certainly contact us, and we'd be happy to get back to you, or contact you with any questions about the webinar. Thanks again for joining, and we hope you have a wonderful day.